I think the major highlight, and of course this was presented in the presidential session, is the data with Abemaciclib in the adjuvant setting. Now, interestingly, we have at the same meeting reported 2 studies that were early reported evaluating a CDK4/6 inhibitor in the adjuvant setting, and one study is stopped because of efficacy, and the other is reported because of lack of efficacy. So totally in opposite direction, and we have some more question than answer, I think, after having seen this presentation. But we have to say first, of course, this is a very early report of the data. We are talking about adjuvant endocrine therapy, which will take at least 5 years. And what we see is data reported with a median follow-up of 2 years. Of course, the treatment by the CDK4/6 inhibitors is limited to the first 2 years in these studies, but endocrine therapy continues to go on. And we know also, in particular in this subgroup of breast cancer, that there will be many additional events in the year that will come. And the major question is if what we pick up so early will really reflect what will happen on the long term. When you look to the data in the first-line setting, it seems that the agents are more similar than different. And here we have 2 totally opposite conclusions. So maybe that for extremely aggressive tumors, the continuous administration of Abemaciclib is an advantage compared to if you give Palbociclib 3 weeks on, 1 week off. Maybe also the question was to give the drug to the patient. With Palbociclib, according to the rules, at the end, a significant number of patients, if I remember well, 40% at 2 years, they've stopped the treatment because of side effects, in particular hematological side effects. But while this number was much lower, about 10% with Abemaciclib. And then, as I said, this continuous administration maybe for highly aggressive tumors is of major importance. Now, and positive trial with Abemaciclib, of course, this is exciting for us. They have so many years that we have not really seen an advance in the adjuvant treatment of breast cancer, and we have the data. Nevertheless, what we are really looking for is to see what happens on the long term. Are we really curing more patients, or maybe this high-risk patient, in particular in the Abemaciclib trial, this were really selected patients with high risk. This is microscopic metastatic disease, which is more advanced, and if you give Abemaciclib, you will postpone the moment of relapse only. So are we really curing more patients? This is the big question we are asking us, and for both trials, it will be extremely important to fully understand if, for example, after 5 years, Abemaciclib trial is really as positive because we are curing more patients, and if Palbociclib trial, the PALAS trial is really negative, as it is reported, or if with time we will see that the patients who had received Palbociclib nevertheless will have some advantage. At this time, unfortunately, there is absolutely no indication that the addition of Palbociclib helps the patient. And then, of course, the other big story at this time in the field of breast cancer is the use of checkpoint inhibitors in triple-negative breast cancer. And here we have seen interesting additional data in the neoadjuvant setting and in the metastatic setting. And here we have also now a very important question: which is the best drug to combine with the checkpoint inhibitor? We have the much better data with nab-paclitaxel than with paclitaxel. Now, does it really matter? It seems so, but it's of course very important for us to understand if the kind of chemotherapy that has to be added is of importance. And then again, it is very nice to see in the neoadjuvant setting now that when we add the checkpoint inhibitor to standard treatments, we have a higher PCR rate. Frequently, indeed, higher PCR means better longer-term outcome. But we are not sure that this applies for all treatment modalities. And for the checkpoint inhibitor in particular, we are really looking now forward to see if by increasing the PCR rate, we are really curing more patients. And then almost the same question also, we know that some of these patients are already cured. How can we identify the patients who really need this checkpoint inhibitor? Because also in general, these drugs are well tolerated. Nevertheless, there are some patients that have really long-term side effects related to the immunotherapy. So many questions still open, but the hope is for us in the field of breast cancer that for triple-negative breast cancer in the near future, we can really perform better by adding immunotherapy to standard treatment. I think we have now repeatedly seen very strong data that suggests that we are going in this direction, and we hope in the near future, in a few years, to have this confirmation, and at the end that we are curing more patients with triple-negative breast cancer.